Hello, my name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Risk Reduction Principles. This is the relevant financial relationship disclosure for this presentation. This is the learning objective that will be addressed during this presentation. These are the key abbreviations that will be used in this presentation. By the end of this presentation, you should be able to answer the self-assessment question. Which of the following risk reduction strategies is an example of increasing error visibility? Is it A, eliminating injectable promethazine from the formulary, B, implementing dose range checking for rivaroxaban, C, ensuring all appropriate antidotes, reversal agents, and rescue agents are readily available, or D, dispensing vincristine in a mini bag of compatible solution and not in a syringe? When we return to this assessment question, I will provide the answer and discuss the rationale. When looking at the primary goal of a medication safety program, it is ultimately to protect patients from harm. This is why we look at medication errors retrospectively. This is why we looked at prospective information to try to prevent harm from happening in our own organizations to our own patients. Humans will always make errors. So while we should always try to prevent or reduce error frequency, we need to also develop systems that prevent harm when any inevitable human errors do occur. When we think about reducing risk of errors, there are 4 principles or buckets that we could fit all risk reduction strategies into. These are preventing errors, reducing the likelihood of an error, increasing visibility of an error, or mitigating harm as a result of an error. We can use fire safety as an analogy. If we want to prevent a fire, well, we can prevent the error by saying this is an area that you should not start a fire in. Let's say it's a high-risk fire safety zone. If we can't stop someone from creating a fire and maybe it's a low-risk area, we can reduce the likelihood of an error from spreading out of control by making sure it's contained within a fire pit. Third, if a fire were to spread, we can implement a principle that increases visibility of that fire, for example, a fire alarm or fire alert system. And finally, inevitably, if a fire does spread out of control for reasons that are out of our control, we can mitigate harm as a result of the error with fire extinguishers or fire safety response team. Now let's take that rivaroxaban 50 milligram case with the dictation error from our last presentation and apply these 4 risk reduction principles to it. We just talked about 4 approaches to risk reduction: preventing, reducing the likelihood, increasing visibility of, and mitigating harm from an error. For preventing an error, a risk reduction strategy was removing the need to dictate a medication list at all in any sort of note. The rationale for this, if there's no need to dictate a medication dose, then we prevent transcription errors from happening as a result of that dictation. For the second principle, reducing the likelihood of an error, we can educate providers that when they're dictating medication doses, they enunciate 1.5. This reduces the likelihood, obviously though it doesn't prevent the likelihood, that a transcription error could occur. For the third principle of increasing visibility, we can implement dose range checking for rivaroxaban. In this case, the dictation or transcription error could lead to a clinician trying to order the dose, but a clinician would be alerted and a pharmacist would be alerted if that dose is in fact too high. This didn't prevent that error from occurring, but it did increase and draw visibility to it so that we can prevent it from reaching the patient. And finally, for mitigating harm as a result of an error, it would be important to develop a protocol for management of anticoagulant overdoses. If the dictation error were to lead to a patient receiving 50 milligrams of rivaroxaban, a management protocol would help by being in place to reduce the likelihood of bleeding. We are now going to take ISMP's targeted medication safety best practices for hospitals to help illustrate some examples of the 4 risk reduction principles. The first principle is preventing the error. One best practice is to eliminate injectable promethazine from the formulary. In doing so, we would prevent an error related to serious tissue injuries from either extravasation or inadvertent arterial injection. Another best practice is to measure and document weights in metric units only. While I agree that doing that doesn't eliminate all weight-related medication errors, it would prevent the type of error where a nurse is trying to convert pounds from a scale into kilograms and being documented in the medical record. A third example of a best practice is to verify and document a patient's opioid status and type of pain before prescribing and dispensing extended release and long-acting opioids. While this best practice alone may not prevent the error, a way to strengthen this risk reduction strategy and therefore prevent the error may be to require documentation of the information and drive appropriate prescribing of opioids through order sets only. That would reduce the likelihood an extended release or long-acting opioid is ordered for an opioid-naive patient. Here are some examples of ISMB best practices that illustrate reducing the likelihood of an error. For example, dispensing vincristine in a mini bag of compatible solution and not in a syringe certainly reduces the likelihood of vincristine being injected intrathecally. A second best practice is to use a weekly dosage regimen default for oral methotrexate in electronic systems when medication orders are entered. We could also require verification of an oncologic indication for daily methotrexate orders. So again, depending on how this is implemented, this could only be a default and not necessarily a lockdown. If it's a default and someone can go ahead and change that frequency to daily, then the likelihood of daily being ordered for a non-oncologic indication is reduced but not prevented. A third best practice is to segregate, sequester, and differentiate all neuromuscular blocking agents from other medications where they're stored throughout the organization. By limiting availability, we reduce the likelihood of inadvertently using a neuromuscular blocking agent. But it is still possible for a pharmacy to dispense this and for this medication to be given in error. Finally, we can limit the variety of medications that can be removed from an automated dispensing cabinet using the override function. This reduces the likelihood of accessing an incorrect medication, but certainly doesn't prevent it. We have several examples of increasing visibility of an error with ISMP best practices. For example, if we place auxiliary labels on all storage bins or pockets that contain neuromuscular blocking agents, we can clearly communicate that paralysis will occur and ventilation is required. You can also configure automated dispensing cabinet alerts that require users to acknowledge clinically relevant information prior to removal. Should a neuromuscular blocking agent be obtained for a patient in error, the warning labels and automated dispensing cabinet alerts could increase visibility of the incorrect medication. A second example of a best practice is to administer all medication and hydration infusions via a programmable infusion pump utilizing dose error reduction systems. The utilizing dose error reduction systems is the key because those are the alerts that would increase visibility of a pump programming error. I have one ISMP best practice that is a great example of mitigating harm as a result of the error. Ensuring all appropriate antidotes, reversal agents, and rescue agents are readily available is a good way to make sure that if an error reaches a patient, a reversal agent and protocol is in place to reduce the potential for harm. So let's go back to our self-assessment question. Which of the following risk reduction strategies is an example of increasing error visibility? Is it A, eliminate injectable promethazine from the formulary, B, implement dose range checking for rivaroxaban, C, ensure all appropriate antidotes, reversal agents, and rescue agents are readily available, or D, dispensing vincristine in a mini bag of compatible solution and not in a syringe? The correct answer for this question is B, implementing dose range checking for rivaroxaban. Letter A, eliminating injectable promethazine from the formulary, is a good example of preventing an error. B, as we discussed, is an example of increasing error visibility. C, ensuring all appropriate antidotes, reversal agents, and rescue agents are readily available, is a good example of mitigating harm as a result of an error. And D, dispensing vincristine in a mini bag of compatible solution and not in a syringe, is a good example of reducing the likelihood of an error. In conclusion, we reviewed 4 risk reduction principles. The goal of implementing any of these risk reduction principles is to protect patients from harm. If we can aim to prevent harm to patients by preventing errors, that's always ideal, and we want to aim for that whenever possible. These are the references used to develop this presentation. Thank you very much for your time and participation.